Hello and welcome to today's featured research spotlight featuring ADAA's 2021 Donald F. Klein Early Career Investigator Award runner-up, Dr. Hilary Weingarten. The annual Donald F. Klein Early Career Investigator Award is presented for the best original research paper on neurobiology, psychopharmacology, psychosocial treatments, or experimental psychopathology of anxiety disorders and depression. We would like to welcome Dr. Hilary Weingarten, who is a psychologist at Massachusetts General Hospital and an assistant professor at Harvard Medical School. Dr. Weingarten's research focuses on cognitive and emotional risk factors for adverse outcomes in obsessive-compulsive related disorders and on applying technology to enhance assessments and interventions for OCRDs. Thank you for joining us today, and thank you for sharing your research with us.
Hi, I'm Hilary Weingarten, and I'm going to be sharing some data that my co-authors and I recently published, looking at rates of remission, sustained remission, and recurrence in a randomized controlled trial of cognitive behavioral therapy versus supportive psychotherapy for body dysmorphic disorder. And thanks to my co-authors who are listed here. These are my disclosures. And many thanks to our funding sources for this project. Body dysmorphic disorder involves a preoccupation with a slight or, if it's present, or with a slight or imagined defect in a person's physical appearance. And that preoccupation is accompanied by really generally time-consuming repetitive behaviors that the person does to try to fix or hide or check their perceived defect. And BDD is surprisingly common and severe. So it occurs in between 1.7 to 2.9% of the population. And we see broader outcomes among people with BDD that are pretty shockingly severe. So we see functional impairment really in all domains, basically experienced universally among people with BDD. So impairment at work, impairment in relationships. We see rates of comorbid major depressive disorder that are sky high. Between 75 to 82% of adults with BDD have comorbid MDD. Quality of life in people with BDD is shown to be roughly 2 standard deviations below normative samples. And insight in people with BDD tends to be poor or even absent, meaning that people with BDD often have delusional insight, believing that their perceived defect truly is an appearance defect as opposed to a reflection of psychological symptoms. And cognitive behavioral therapy, or CBT, is the psychotherapy with greatest empirical support for BDD. So in a recent large randomized controlled trial by Sabina Wilhelm, Kathy Phillips, and colleagues of therapist-delivered CBT versus supportive psychotherapy for BDD, the primary outcome that they examined in this trial was responder status. And responder status has been consistently documented in clinical trials for BDD, and it's defined across trials as a 30% or greater reduction in BDD symptom severity on our gold standard clinician-administered measure of BDD severity, and that's the BDD-Y box, or Yale-Brown Obsessive Compulsive Scale Modified for BDD. So using that outcome of responder status, Wilhelm and colleagues found that response rates after a course of CBT across sites range from between about 83 to 85%. And response rates for supportive psychotherapy, or SPT, across sites range from about 46 to 69%. So these response rates for CBT in particular are really robust. Up to 85% of people who've completed or who were assigned to this course of CBT were classified as responders. And this result, in conjunction with sort of the prior literature leading up to this, really points clinicians to CBT as a treatment of choice. That said, Wilhelm's recent randomized control trial did not report results in terms of remission rates. And remission is when you become fully or partially symptom-free after treatment. It's a key efficacy benchmark that is meaningful to clinicians and to patients. It has this inherent meaning. When a patient comes into treatment, they want to know, what's my likelihood after I finish this treatment that I'm going to be meaningfully symptom-free after this. So I'm going to have a really meaningful alleviation from my symptoms. And we don't have a great answer to that question at this point in time. And that's really because, Wilhelm and colleagues' trial was not unique in not reporting remission rates. Most of the clinical trials for BDD out there have not reported outcomes in terms of remission. That's partially because we haven't had a standardized way of measuring remission like we do for responder status. And so the few studies out there that have looked at remission outcomes in CBT for BDD trials, their results have ranged hugely. Their remission rates are as low as 19% in one trial, as high as 82% in another trial. It's very difficult to sort of pull a conclusion from the existing data. So recently, Fernandez de la Cruz and colleagues in 2019 established a validated operational definition of remission in BDD trials. And they showed in this paper that I show here from Psychological Medicine that full or partial remission mapped onto a BDD Y-box score of 16 or lower. And that cutoff of 16 or lower has strong sensitivity, specificity, and precision for detecting clinical global impression severity scores of 1, which means normal or not at all ill, or 2, which corresponds to borderline mentally ill. So basically, a score of 16 or lower corresponds to no symptoms or very sort of minimal subclinical symptoms. So now we have this validated definition of remission. So we can use that as a standard for measuring remission in BDD clinical trials moving forward. So that standardized definition, kind of in conjunction with this rigorous RCT that was recently completed by Wilhelm, Phillips, and colleagues, gives us this opportunity to sort of establish some new best available estimates of remission rates after psychotherapy for BDD. So that brings us to the aims of this study. So as I just mentioned, our primary aim was to obtain some of the best available current data on remission rates following psychotherapy for BDD. And we used data from Wilhelm and colleagues' large face-to-face randomized control trial of CBT versus supportive psychotherapy or SPT for BDD. And we used Fernandez de la Cruz and colleagues' new validated definition of remission. And with that information, we aim to estimate full or partial remission rates at end of treatment. Our second aim was to estimate rates of delayed remission, sustained remission, no remission at any time point, or recurrence at our 6-month follow-up. So aim 1, what are the rates of remission at end of treatment? Aim 2, what's happening for participants in our trial at 6-month follow-up in terms of remission and related outcomes? And our third aim was to test whether broader mental health symptoms also improve meaningfully upon remission from BDD. And so we looked at those outcomes that I was just talking about that we know are affected in people with BDD. So functional impairment, depression severity, BDD-related insight, quality of life. Do those improve alongside remission? That's useful to know because as clinicians, if we have data to support that, then we can really tell patients, as you improve in your BDD across this treatment, we also are very hopeful that you're going to see sort of broader meaningful improvement in these other domains of your life. So I'll dive into the methods. I'll first point you just to the primary paper for this trial, this randomized control trial, if you want to dig into the clinical trial methods in more detail. So our participants, this was a secondary analysis from that 2019 Wilhelm and colleagues RCT. We had 120 participants who were recruited from 2 sites, Massachusetts General Hospital and Harvard Medical School, and then Rhode Island Hospital and Brown University. And the primary eligibility criterion was adults with a primary diagnosis of BDD and at least moderately severe BDD symptoms. So that's determined by a BDD Y-box score of at least 24. So we used several clinician-administered gold standard measures. These were administered by trained, reliable, independent evaluators who are blind to the treatment condition of the participant. And this included the SCID 1 and 2, which we used to assess Axis 1 and 2 diagnoses, the BDD Y-Bucks, which I already told you about, our gold standard clinician-administered measure of past week BDD severity. The BABS, or Brown Assessment of Belief Scale, is our gold standard measure of BDD-related insight. We also administered some validated and reliable self-reports to capture some broader outcomes. So the Sheehan Disability Scale, or SDS, is our measure of functional impairment. The BDI-2 was our Beck Depression Inventory 2, of course, was our measure of depression severity. And the Quality of Life Enjoyment and Satisfaction Questionnaire short form was our measure of quality of life. In terms of key study procedures, participants were randomly assigned to their treatment condition, either CBT or supportive psychotherapy. In both conditions, they received 22 sessions of therapy, and those were spaced out over 24 weeks. So at the very end, they just had sessions spaced out every other week to taper down. In both conditions, any participants who were treatment responders at the end point were offered booster sessions at 1 and 3 month follow-up. And in both conditions, therapists followed manuals and were assessed for adherence and fidelity. And in the SPT condition, I should mention, the therapists used the Pinsker manual, and they also enhanced that treatment with some pretty robust BDD psychoeducation that was, similar to what was given in the CBT condition. Okay, so I'll dive into results and discussing those results. So just to remind you, our first aim was to estimate the rates of remission at end of treatment. And we used multiple imputation to handle missing data and to estimate our rates of remission by treatment condition. So this is a graph of our remission rates after a course of CBT or supportive psychotherapy. And the error bars are 95% confidence intervals around those multiple imputation estimates. So overall, we found a remission rate of 68% in the CBT condition and 42% in the supportive psychotherapy condition. And that rate in CBT was significantly higher than it was in SPT, as you can see here. And if you're interested in how these rates broke down by treatment site or by study site, then we do report that in a supplemental table in the paper. So overall, in terms of what to take away from this primary finding, so first of all, the remission rate following CBT in particular is really encouraging. It provides, 70%, almost 70% of people who were assigned to CBT were classified as remitters at the end of treatment. And just having that data point for both of these treatment conditions, CBT being the treatment of choice, supportive psychotherapy probably being the most commonly received psychotherapy in the community for folks with BDD. So having just those two benchmarks, it really fills a gap in our data around efficacy for psychotherapies for BDD. And I think based on these data, clinician can feel comfortable telling prospective patients at the outset of a course of CBT, I'm really hopeful that you will experience partial or full alleviation from your BDD symptoms over the course of this treatment, or meaningful alleviation of your symptoms. Our second aim was to estimate remission and recurrence during the 6-month follow-up period. And again, we estimated these outcomes using multiple imputation. For these aim 2 analyses, we were not powered to test for significance between treatment conditions. So we look at the difference in rates of these different outcomes across conditions just descriptively. So again, here are multiple imputation estimates, and then the error bars for these also represent 95% confidence intervals around our estimate. So we first looked at delayed remission, which I show here. And delayed remission is participants who were not in remission at end of treatment, but they were in remission at the 6-month follow-up. And we found that 10% of those who completed CBT and 14% in the supportive psychotherapy condition experienced delayed remission. And, this just suggests that some patients need just a little more time to consolidate their learning, perhaps. There's this handful of patients in each condition who weren't remitters at the end point, but sort of when left to their own devices during the 6-month follow-up, seemed to take something additional away that got them to that remitter status. So we next looked at sustained remission, and that's participants who are in remission at end of treatment and then stayed in remission at both our 3 and 6 month follow-up time points. So we found that roughly half of participants assigned to CBT and roughly a quarter of participants assigned to supportive psychotherapy not only had achieved remission at endpoint, but then sustained that remission across the 6-month follow-up period. And these findings, especially the CBT findings, I think are really promising in terms of maintenance of gains. That you know, half of people who were assigned to CBT still were remitters 6 months after they finished their treatment. That said, there's also room for improvement in both of these conditions. And to me, that makes me think that, you know, there are patients who probably would benefit from more than just those 2 offered booster sessions. So if you remember, participants who were classified as responders at endpoint were offered 2 booster sessions during the follow-up period. And there was a high overlap between who were responders and who were remitters. And so, you know, these folks, they might be better off if we offered them 3 or 4 booster sessions during that 6-month follow-up period. So third, we looked at participants who never achieved remission at end of treatment or at 6-month follow-up. And so that consisted of 18% of the people assigned to CBT and 45% of people assigned to supportive psychotherapy never achieved remission at any time point. And these results highlight that, you know, while remission rates were strong overall, current therapy options don't work for everyone. And we see this, you know, time and time again across clinical trials, across disorders, that there are always those, you know, that stubborn sort of treatment resistant subsample that just doesn't respond like we hope that they will. To me, these findings, you know, they really point to the potential relevance of future precision medicine initiatives, you know, down the line, the hope that we may be able to match an optimum treatment to the individual patient to hopefully figure out, you know, if you don't respond to this, what do we think you're most likely to respond to that we have sort of in our toolkit to offer? And last, we examined rates of recurrence, or those participants who were in remission at end of treatment, but not in remission at either the 3 or 6 month follow-up. So 20% of participants in the CBT condition and 14% of participants in the supportive psychotherapy condition experienced a recurrence of symptoms. And overall, these rates, you know, I think again, they point to the potential value of some additional booster sessions after treatment ends. The other thing that this makes me think about is potentially more novel step-down approaches to maintaining gains. So in our program at Massachusetts General Hospital Center for OCD and Related Disorders, we've been developing and testing, for instance, a cognitive behavioral therapy smartphone intervention for body dysmorphic disorder, something like that. You know, there are strong internet-based CBT for BDD programs already out there from Karolinska. So programs like that could offer, you know, potential for step-down care that's low cost, disseminable, easily accessible. So I think that merits some additional research. So this slide really just gives you an alternative way of looking at those 6 months outcome data that I just walked you through on in individual slides. So I've shown each outcome here broken out by CBT, supportive psychotherapy. So while we couldn't compare these differences statistically, it just gives you a visual where you can see some of the more sort of dramatic differences in proportions. So in blue, you see the rates of delayed remission in each condition. In red, the rates of sustained remission in each condition. In green, no remission, and purple shows those who had recurrences. Okay, and our final aim was to examine how broader mental health outcomes changed among participants who experienced remission from their BDD across treatment. And to test this aim, we used t-tests to compare those broader mental health symptoms among remitters compared to non-remitters at the end of treatment time point. Okay, the slide has a lot on it, but I'll walk you through it. So overall, what you're looking at is our 4 different outcomes, and separated by remitters in green, non-remitters in red. And I put these are just showing the means with standard errors. So overall, what you should take away from this slide is that remitters showed significant improvements in each of these 4 broader mental health outcomes at end of treatment compared to non-remitters, each with large effects. So you can see in the top row, we've got Sheehan Disability Scales, our measure of functional impairment, our measure of depression here. For both of these, you can see functional impairment and depression severity were significantly lower among remitters compared to non-remitters at end of treatment. Over here, we're looking at insight. Lower scores on the BABS corresponds to better insight. We saw better insight at end of treatment among remitters compared to non-remitters. And on the Q-less-Q, higher scores correspond with better quality of life. So here we're seeing higher quality of life among remitters compared to non-remitters. These results, I think, they can also be shared with patients to instill hope that, if you improve from this treatment, we also hope that you will and expect that you will experience meaningful improvement in terms of the impairment you're experiencing from your BDD, your comorbid depression symptoms, your insight, and your quality of life. To give you a better context for where remitters landed in these broader mental health outcomes at the end of treatment, in terms of functional impairment and depression severity, over 80% of remitters reported non-clinical levels on these 2 domains at end of treatment. So they really were amongst the same pool as, a healthy normative sample in terms of impairment and depression severity, if they were remitters. In terms of insight, if you remember, I mentioned at the beginning of the slide that, most people with BDD have poor or absent insight. And what we found is that our remitters at the end of treatment fell in the range of having good insight on the BABS. So a really meaningful improvement there. And then in terms of quality of life, our participants who were remitters fell somewhere between normative samples without a current mental illness and samples with a current mental illness. And so quality of life was the one domain that you're really not restored to a full, a full restoration compared to people who, aren't experiencing a mental health symptoms or mental illness. And, if I think about why that might be, one of the explanations that comes to mind as a possibility is just that quality of life really taps into things that take some time to change. It taps into relationships, jobs. It takes time to get a new job or, experience job improvement or to get a new relationship or experience meaningful relationship improvement. So that outcome of quality of life, it's possible if we had measured it further out, maybe we would have seen more restoration among our remitters. But of course, that's just a guess. Okay, so there are a couple of limitations to consider in this work. First, because the Fernandez de la Cruz definition of remission combines full and partial remission together, we couldn't separate these as distinct outcomes and examine them separately. And in order to do that, you'd really need to combine data from across multiple clinical trials in order to have enough power to validate separate definitions of full and partial remission first, and then go back and look at these outcomes. Second, this is a longitudinal treatment study, so there was missing data. And it's very possible that those data were not fully missing at random. It's quite possible that people who were not doing as well at the endpoint or follow-up time points were those who were less likely to come in for those follow-up assessment visits. And so we use multiple imputation as our rigorous method for handling missing data. So taken together, these results likely offer the best available current estimates of remission after therapist-delivered cognitive behavioral therapy and supportive psychotherapy for BDD. Past studies have looked at predictors of improvement and remission, and those studies looking at predictors have shown that patient expectations of the treatment and credibility of the treatment predict improvement. So keeping in mind that expectations and credibility of treatment predict improvement, it makes sense, and I'm sort of a broken record here, but it makes sense for clinicians to share these outcomes with prospective patients to really instill hope. And in turn, instilling that hope at the outset of treatment that this treatment really could work. It can potentially boost remission rates even further. So to close, I wanted to provide the citation for our full manuscript in case you want to delve deeper into anything that I talked about or take a closer look. Thank you so much for your attention, and don't hesitate to reach out to me.
Visit ADAA.org for all the updates on the ADAA 2022 awards programs. Applications open June 2021. If you are not yet an ADAA member, please visit our website to learn more about our many member benefits. Thank you so much for joining us today. Please explore the many upcoming live webinars in our on-demand library. Have a great day.